When I play the maracas, I go chick, chicky, boom, chick, chicky, boom. Hey!
Live from Studio A.
It's Cuba Pete.
It's Cuba Pete. No laughing matter.
So, Joe, you dragged us out here, so why don't you tell us why you did this to us?
I was forced into this.
well, why don't we ask the person who's really responsible?
Yes.
So, Renee, why don't you explain to us, how we all arrived here in Las Vegas at Roseman University?
Yeah, ultimately it's my fault. Absolutely. Roseman University, we are a health professions university, not-for-profit, a very unique institution, founded about 21 years ago. And we came here to found this. I am one of the co-founders. We came here to found this institution because we really wanted to fundamentally change how health professionals were trained and educated in the United States and make a real difference. And it's really important to understand that it's very difficult to really make substantive changes in the educational system in universities in existing institutions. It's like trying to turn the Titanic. So being able to start from scratch with a vision in mind and then being able to work toward that vision in a way that's not hampered or encumbered by pre-existing hierarchies, organizational structures, preconceived ideas, preconceived notions is really freeing and liberating. And as we have moved along in our development and wanted to start a college of medicine to complement our other health professions programs and really create the ultimate opportunity for this institution to move to the next level, it was with the College of Medicine. And, once we heard Cuba Pete or Joe talk about his vision for medical education and knowing our vision for what we wanted to do in educating healthcare professionals, there was just such a match there. It's a match made in heaven. And so we said, let's get Cuba Pete here. And you bring with you your team that's going to make this happen. So bring to me the dream team, and voila, dream team in front of me.
And that they are. They really are the dream team. I mean, I'm humbled to be both yours and their colleagues. And I think that what we did was we looked at what was the problem. What were we doing wrong as medical educators? And how do we resolve it to improve the care in this country, decrease the disparities, increase the diversity of medical education, both the educators and the students. And everybody comes here with very different academic backgrounds. And I'm going to let Lou, actually at this table, I'm the only one with 1 degree. So I'm sort of embarrassed, but anyways, Lou, go ahead.
It's a very lucrative degree.
Right. It worked out well.
Right. We all have, I think our collective degrees
don't add up to
the collective wealth that has been generated by your 1 degree. But hey, if it works for you.
Yeah, but I have 2 kids.
Oh, okay. All right, fair enough. So I guess my goal here, or my role here, is to integrate the community component of it, right? Because at the end of the day, we work on behalf of the community, right? That's at the end of the day who our clients are, who our patients are. I think sometimes we forget that part, that patients actually come from real lives. They have families and jobs, and they have challenges getting around, and they places to eat, and et cetera. And so that's my role, is to kind of bring some closeness between the people that we're educating and the people that they hopefully will care for. And so if we can do that, then that's success.
And I think that's simplifying the complexity of what you do, because the other thing you do, Lou, is actually develop delivery systems. Develop delivery systems from the perspective of the patient, not the perspective of the physician. And I think that is something that is incredibly unique.
Well, yeah, but the thing there is that they're really all it is being a broker of all of the other things that people do well, right? So none of what I'm able to do can get done if we don't recruit diverse students, right, who can speak the languages in the areas that we go to. We can't do this if the faculty that Marin has to train do not know how to work. I'm just saying, don't know how to work with these communities. And if the students aren't competent, if they don't know the actual skills that Karen is trying to teach them, then I could do more harm than good bringing these individuals out to the community. So as complex as it is, it's even more complex what each one of us are called to do to bring it all together.
And talking about diversity, the importance of the diversity is that has to be at the very top of the leadership. And with that, I'd like to introduce Cheryl Brewster, whose last of like 27 degrees was at her doctorate in education at Columbia, but she's our Senior Executive Dean for Diversity, Inclusion, and Equity, as well as the pipeline. But you're on.
Oh, thank you, Joe.
You have 20 seconds.
I get no respect, you know?
So, yeah, I mean, I think, I've been doing this work for well over 10 years, and understanding a lot of what Lou just said, I think is important, but I have one job, but I have many roles, and I'm integrated throughout the entire College of Medicine, from faculty, staff, students, to policies, to curriculum. So it is exactly what Lou said, ensuring that the workforce is diverse, both at the student level and for future physicians, as well as at faculty level, student level. I mean, it's across the board, ensuring that we have diversity, equity, and inclusion. So you can have diversity, but if you don't have equity and inclusion, it doesn't really matter what you do, because then people don't feel like they have a sense of belonging. And that is what I'm here to do, create a sense of belonging for employees and staff here at the College of Medicine.
And, one of the interesting things is that extends beyond our own college.
It definitely does.
Because it's the collaboration we have with the entire university.
Yeah.
Something that, universities...
Explain how the university is set up and how that works.
Well, you have different colleges. And then actually we're going to be using through the Genesis program the start of the IPE, or the interprofessional education.
And Dean Greer, what are those colleges?
These are the college, it started off with the College of Pharmacy, the School of Nursing with graduate nursing, dentistry with graduate medical education programs, and orthodontics that we have down here and in South Jordan. We also, up in South Jordan, there's also nursing with nurse practitioners.
Wow.
Wow, Joe took his Ginkgo biloba today.
Wow.
Holy wow.
Just because I have white hair does not mean I have lost all my memory. Just most of it, okay? And that's something that's very, very unique in higher education. Everybody talks about collaboration, and generally a medical school's collaboration is we have a Saturday clinic with medical students and nursing students, and that's our collaboration. We're talking about collaboration at all the different points. Actually, the importance of this collaboration is, Karen, why don't you talk about how you want to educate our medical students from a therapeutic perspective because of the School of Pharmacy. And Karen is our Senior Executive Dean for Academic and Student Affairs, and the only one of our team that has actually walked across the Alps.
Slow jog.
So my job here is to oversee the development of the curriculum and do as much integration as possible with some of the other health sciences colleges. That's one of the things that makes it exciting to be at a health sciences university, is that we can do some of these things together. Obviously, our first goal is just to produce really excellent physicians, but we want to do that in a way that really prepares them for the future, so that they understand the social determinants of health that are so important to our patients, that they develop a real comprehensive knowledge of basic sciences that's rooted in therapeutics. We really want to have them understand the mechanisms behind medications they're prescribing, other things that they're recommending to patients. And then
and by the way, Karen, that is a very unique way of educating medical students.
So the plan is to use that kind of perspective to really anchor that knowledge in a way that they'll be able to continue to refer back to during their practice. There's so much changing right now, or changing so quickly in medicine, that in order to stay on top of things, in order to stay current, like just look at what we have, with COVID, for example, right? All new vaccines, new mechanisms. It's really important to have those fundamentals so that you can keep adding to your knowledge base. and to do it in a way that really respects the student experience and makes sure that they have a great time while they're going through school as well.
And what's important as we prepare the future workforce of physicians and other health professionals is the underlying importance that we all feel of both ethics and the ability of these individuals, if they're going to be change makers in the future, to be able to tell a story. And that comes with Dr. Maren Gillis, who is a philosopher and happens to chair the Cambridge Consortium for Bioethics, and is one of the most respected bioethicists in actually the world.
Thank you very much. I'm also Canadian, so I'm even more humble than.
No one is humble that says,
Oh, wait.
I'm humble.
You can't say I'm humble, right? How does that work?
Does she come from a country that has universal health?
She does.
Oh, okay.
What, pray tell, is that?
I don't know, but by the way, if you go to Canada, don't ask for Canadian ham. They call it ham.
Canadian bacon. Well, it's,
Canadian bacon.
Exactly. Well, it's exciting to come to Vegas and be back in the West, and it's exciting to be part of a place that values education. And when we talk about education, we're always thinking of the students, but we never really think about the educators. And something that is, from top down at Roseman is that the faculty themselves have to be prepared to be good educators, and that we're trying to tell the world that if you're a Roseman grad, that you can have a certain guarantee of a certain way that student's going to be, and it's because the faculty are prepared to teach them. And one of the things that, and I wanted to pick up something that was from what Lou was saying, when we're talking about the community and we're looking at where the patients are coming from, in a lot of health profession schools, and I've taught at a bunch of them, all health professionals care for patients and they want to have patient-centered care, but our perspective is completely different on that. And it's wider because you can respect a patient as a person, you can talk about family-based care, you can talk about the biopsychosocial model, but we're going a step beyond that. We're going into the social determinants of health, which unless you address those, we really can't talk about health at all, right? And we're not setting up our medical students who are graduating to be able to deal with the consequences of that in the world, and that's what they're going to be addressing, right? That's what's on the line for them. So we're preparing them for it with solutions, and because we want our students to be change makers.
100%, because one of the most important things is medicine is going to be going through crucial changes in the next couple of decades, and we see that because of COVID. It's not just the technology, but also the realization of these disparities which we've known. But which, by the way, it was 1985 when the very first report of minority health ever came out in this country. And it wasn't until the late 80s that it actually got funding for its appropriation. So the United States is not, it's sort of new at this game, but the reality is the disparities are embarrassing. Right now in America, your zip code, it's 100%. Your zip code is more important than your genetic code for your morbidity and your mortality, how long you'll live or how you will suffer. And we need to resolve these things. If we're going to be leaders in this arena, the expression of what happens in Vegas stays in Vegas. Well, what happens at Roseman, we want the world to know.
And that's what it's exciting, being able to start from the ground up.
Yeah.
That's one of the reasons because I think we all remember, and when Joe came up to each of us and said that our lives were about to be abruptly changed, and we were kind of in shock,
Yeah, I remember talking to you, Maren, about it.
I remember that, and I grabbed you in the hallway and I went, Vegas, Lou? Really?
And what did I say, though?
I remember what you said. You said, when are we going to have another opportunity? When are you said to me, when are you ever going to have an opportunity to be involved with an enterprise starting from the ground up, with starting a medical school? And then you also said to me, and when have you ever failed at anything? And I went, oh, Lou.
He's a good butterer.
It was all over. I went, oh, come on.
It's true, though.
I tell that story a lot because, and I had been in Nevada before, and I love Nevada. I mean, I'm sure you guys, it's different. The mountains are pretty overwhelming, but every morning when I wake up and I see the mountains,
I know, it's spectacular.
It's very different.
It's very different, but my God, they're glorious.
It's inspiring.
Yeah.
It's inspiring. Now, I don't hike. That's Karen's department. She is like the in-house hiker.
Neither do I.
And she's silently on a mission to get all of us to hike. I'm recognizing that more and more each day.
I am on a mission.
Yes, yes.
I got new boots. I'm ready.
Can you explain your progress in this mission, Karen? Because I'm just curious as to why you are on that quest.
Well, so far, not only has Cheryl come hiking, Cheryl has actually taken other people hiking. So I'm making slow inroads into the team.
Okay.
She saved my marriage. We've been married 40 years.
Yeah,
Janice has wanted me to go hiking. And I said, but you can go with Karen.
And so she does.
Such a and so a romance began.
Yeah, it did. However, I have to have a full meal prepared for them when they get back, okay?
We work up an appetite, Joe.
I didn't know there were so many supplies related to hiking, too. Apparently, Joe's been doubling down on supplies as well.
Yes.
Yeah, backpacks, hiking poles, boots.
Yeah, I got the poles, the boots.
Yep.
Renee, you hike too?
Oh, yes, she does. Her and Harry.
Harry Rosenberg, the other co-founder of Roseman, was actually not just a hiker, but a mountain climber.
And a glacier climber.
Climbing like different peaks across the United States. And yeah, so he, I'm blanking on the name of the big peak in Washington State.
Karen?
Yep, Karen?
Big peak in Washington State that he's climbed several times. So yeah, and he did sabbatical in New Zealand and spent tons of time hiking in the mountains in New Zealand. So he's a big hiker. So he's the one that got me into it.
Wow. Yeah. Okay.
We come from Miami, which is sea level.
Yeah, you got to get out of sea level.
That's right.
But it's so inspiring out there.
No, it's amazing. And the nice thing is during COVID, we've been able to get out and do stuff and not be cooped up in the house. So that's been kind of nice because, we came from the beach. So it's a very different environment. So.
Well, here they have a lot of beach, just no waterfront.
So it's been kind of cool to do something different and allow us to get out and get some fresh air.
It's been great. My wife, Janice, she really loves it out here. She really, really does. And of course, it's always really nice not to have to worry about hurricanes.
Yes, very much so.
Although that wind last Saturday
was crazy.
Was 74 miles an hour. It was 1 mile an hour off of Category 1. The wind was so bad, and we didn't realize how bad it was, that Janice looks at me and goes, "Did you move the outside furniture?" I said, "No."
So Renee, what is the question you've always wanted to ask us? Especially now that we've been here for a little while, that you haven't had a chance to ask.
Well, with you guys, it's interesting to talk with you all because it's like the sky is the limit with you guys. And what I appreciate about you all is, and I think as the co-founders, I think we feel some kindred spiritness with you all. Is it seems as if you guys don't put limitations on yourselves. Mm-hmm. And, it's like, okay, how do we make this happen? And so, one of the things that's always inspired me is taking this sort of Stephen Covey approach, I call it, to how we're moving forward. And that's begin with the end in mind. That's, right. One of the things that Stephen Covey has is 7 Habits of Highly Effective People. And it's amazing how much clarity you get from that, right? Because then you can see the end goal and you just figure out how to get there. So how has the journey been for you guys in the past, what has it been, 6-7 months that you've been here, in thinking about what the end's going to look like, and then your journey in planning on how to get to that end vision that you have?
Let's talk about Genesis.
I know that, for one thing, it is so exciting to be a part of this process. And that's the way we approach it every single morning. We approach it every single morning, and one of the rules we have is, even though I'm the dean, they all have to agree to disagree with me constantly. So we're
good at that.
They're good at that. But what it is you have these 4 incredibly intellectual, ethical, led by social justice, brilliant minds working together from different disciplines to make something work. It was like, Lou figured out how do you take social systems that look at families and medical systems that look at individuals and marry them into one so that we can make these systems work. Nobody thought about doing that. Karen is developing a curriculum that is, in my estimation, is going to be fantastic, beyond fantastic.
A model.
A model. And being both academic and student affairs, she can marry both curricular and not curricular things to produce the very best physicians that we can. With Marin, we have somebody here that's going to be using learning innovations with studio design teaching, like the MIT Media Lab, hackathons, the arts, the cultures, to be able to produce a student that's not just the best clinician, but also one that can communicate appropriately to not just their patients, but to the general public as changes occur. But that can only be done if we have the proper pipeline, if we have the proper diversity, if there's somebody there making sure that our hiring processes within the medical school follow all these rules. We need to be the most professional, the fairest, the most ethical, the most compassionate. Even though in medicine we talk about empathy and humility, as Marin was explaining to me the other day, empathy is how you get to compassion. They are two different things. And for us, we really want the world to come here and say, oh, is that how you do it? What do you guys think?
Yeah.
I'm excited about how close and interwoven the work that typically I do is seen as external, right? It's like, in the past, it's been, oh yeah, Lou does that community stuff. And so, it's true, right? I mean, that's what I would always hear. Like, he does that community stuff, right? And so, it's been very, very, very rewarding to be able to sit with Karen. I probably sat with Karen too long because she then made me like co-curriculum.
Co-chair of the curriculum committee.
and so I, but the positive to that is that, I'm seeing all these exciting and innovative ways that we can weave the community into our day-to-day lives. And they don't have to be sort of tangential to what it is that we're doing. They're actually interfaced into it. And so the work around looking at practice groups and how we're going to have students organized in practices that will work with communities.
Interprofessional practices.
And interprofessional practices that have pharmacy students, dental students, et cetera, in it. The fact that we'll be able to show the benefit, the growth in a student by their actual ability to perform certain activities in the community is exciting to me.
But it's a two-way thing, right? Because something that, from the beginning, when we all started to work with Joe, he always said, we are not going to helicopter with community. Universities and academic centers go in all the time, and what they're looking at community for is for
data.
Ends. We need subjects to study, and you go in with your grant, you study the people, you write your papers, and then you leave, and the community is going, well, that was nice.
Yeah,
right?
well, meanwhile, you also took all of the money.
And you took all the money, you took everything else. And so to look at the relationship between the university and the community, and from the get-go, we've always, in our minds saying the community are teachers of our students, right? They're co-educators in this
And you plan to make them faculty.
And, and we are developing a faculty line for them called Community Faculty Associates so that they can be developed as Roseman educators.
Yeah.
Right? And they are going to be, because they are part of the teaching program that we have. We couldn't do what we want to do without them as educators.
And Karen wants to use some of the households as opportunities to do assessment on the...
Absolutely. Right.
Yeah, what I wanted to say is that, what you're describing, you've articulated it very well in just a small phrase. And it's something that I've latched onto. I think Joe was the first one that introduced me to it because it's really very powerful. You don't talk about a community-based medical school. You talk about a community-dependent medical school. And there's a huge difference there. And I think what it does is it really takes the arrogance out of the university approach to things and really says, look, we need you, community. And yeah, we hope and we want, our desire is community-centric to improve the community. as a part of the community.
Right.
But we acknowledge that we need you. You're part of us. We want to make you part of us. And that community dependency is a very different model from a higher ed ivory tower. It's not ivory tower. It's we're getting down and dirty with you all, and we want to improve your lives.
Right.
Yeah.
And we know that when we go in, because we're a university, we go in with baggage.
Right.
So it's incumbent upon us to build trust. I'm sorry, Karen. Go ahead.
Oh, I was just going to say, definitely, and trust and relationships, right? Not so with individual households and families, with community organizations, and with our hospital partners and our physician partners, who will be, key to the training of our medical students in the clinical areas, and to make them feel like they're also part of the family.
Yeah.
Lou was mentioning, sometimes things getting sort of siloed, or, this happens over here and this happens over here. And we really want to try to avoid that and have the most integrated curriculum management possible. The students only see it from their perspective, right? They're going to one medical school. They're not going to this program and this program and this program, and then somehow having to figure out how to tie it together themselves. So we want to make sure that we, despite having a very distributed sort of learning environment clinically, that we have ways where we can pull that together for the students and really prepare them to work in all sorts of different arenas in the future. And some of that's going to be through technology, through telehealth, through using all sorts of virtual learning tools that that are now accessible, and really embracing that in part of the learning environment.
And
I
have
want
tools
to
that
kind of go back to something that you mentioned, Karen, and that was the issue of trust. And so and building with the community. And so I think, and it also ties into what Maren was talking about, this is the first time I've been able to write a grant where the co-PI is a community leader who has her own community organization, and to say, we're writing this together, and you get some of the money, I get some of the money, or we, Roseman, get some of the money, but that shows that we are sincere in our, mindset that this is about the community. It's not just about Roseman, and that we are here, as Joe likes to say, in perpetuity. And we are building strategies where we know that these programs are sustainable by building up the community organizations and building infrastructure within some of these really small organizations. I think is important, because that's also community building, right? And we're talking about an organization that works with first-gen students to allow them to see how their organization grows based upon resources that they might not have otherwise had access to, is not just, like I said, it's not just about Roseman, but this is also about the individuals that are impacted as they move through the world to see, oh, this is how it can be done in a more ethical, just way where resources are shared.
But you're also doing it with the other universities.
Yes,
so it's
but
not just sharing with the organizations.
Yeah, but it's and that's just kind of saying we don't own everything.
Right. We're part of everything.
Right.
It's a we.
It's a we. And which is very different from the history of my profession, which tends to be more I. And so we want to change that characteristic. We truly want humble physicians. And one of the ways we do that is by being dependent on the community and sending a student to somebody's household. No longer is that patient coming into the ivory tower, but you're going to somebody's home, and you have to show respect, and you have to observe, and very different than any other medical school, they will be taking care of these families for 3.5 years, longitudinally. So they're going to see exactly what happens to individuals and families and interactions and all that. And one of the most important things that Lou had insisted upon at the prior institution we were at when doing this was the student is not allowed to ask, how do you feel? But what is your most urgent need?
He got it.
You know. Only 15 years later, I got it. Okay.
We were holding our breath.
You guys keep doing it in different languages. and
it's hard to develop empathy from books, right?
Yes.
You develop empathy when you can see, feel, bring in the environment around you. So you can't do that in a classroom. Getting the students into those homes is going to be tremendously impactful. and make a huge difference in their development of empathy and then to the next level of compassion.
Of which, by the way, one of the requirements to be on faculty at the College of Medicine will be that faculty member, whether you're a bench researcher or a clinician or purely an educator, has to make house visits.
Staff too.
So this is something that is for we're fully committed. We're fully in this.
You can't write a grant. You can't teach students about being empathetic, about working in communities if you've never been there. And sadly, the system we have currently, you have people who have multi-million-dollar grants and have never been to the communities that they are studying, know nothing about the individual. So it's kind of sad that we have to tout that as being distinct and unique when it quite honestly should be happening, more broadly.
Well, the other thing that's distinct and unique is what you and Maren bring to the table, which is in every single case presentation we're going to have, the student has to be able to predict ethical dilemmas that might occur, or what were the ethical dilemmas that occurred that got the patient to this position, as well as what are the social determinants that might have exacerbated or caused this disorder, and how do these social determinants affect your decision in therapeutic interventions in a patient? How does this work? Because these social determinants depend on everything from food inequities, to employment, to income, to housing. And that's why the student asks, what is your most urgent need? Because they need to realize that it's not getting your colonoscopy done. It might be paying your rent.
Right.
It's not, it's not about my annual checkup, but I got to make sure my kids get to school. I'm working 3 jobs. I have no benefits. So every day I take off work to go see a doctor, guess what? I lose 20% right then and there, not even including what I have to pay. Right. Oh, I got to do daycare too. So, the realities that exist out there have to be seen in its totality for a student, not encapsulated in this is the disease, here is the treatment. There's a lot of variables. We have, evidence-based protocols, which have variances in them that you could do when you do these different things. So,
Well, one of the things is when you're speaking about this is that there's a lot of literature about the experience of medical students. Once they come into medical school and the reasons why they want to come into a health profession, and it really is to help people. And that something happens by the time they hit their 3rd year where there's something called empathy erosion. And of the things when they study this, why it is because most medical students and health profession students learn on the bodies of the poor, and so they have folks coming into, let's say, a hospital setting, and they know that when they're putting them out there, but putting them back, they're just going to come back in. And it's very disheartening because the students go, what can I do?
And you see that subsequently when they become physicians, because one of the things is when you apply to medical school, you say you want to take care of everybody.
I want to help.
Right.
I want to help. You do a white coat ceremony. You take a pledge. You take an oath to do what you're going to do. 2/3 of your educational dollars are paid for by the public dole, which means that the public is paying for it. When you learn to do a procedure, you're learning to do that procedure most likely on an uninsured indigent patient in the hospital. When you graduate, you take another oath. And where along all this place, those that trained us to be physicians, do we go out and say, oh, you have no insurance, I'm not going to see you? Or we'll set up this little clinic for you here. So I look at that as, wow, we use people to train to be where we are, and then we ignore them.
We forget them.
After we make money, and we make money.
Well,
We make lots of money.
But it has to be more than just making money. We're going to make a good living anyways. But we need to be leaders in society. We need to have to change policies. We need to say this is what needs to happen. And, the old thing of, I don't want to be like England or Canada. Well, every time I've gone to England and Canada, everybody boasts about their health system. For goodness sakes, during the Olympics in England, the opening ceremonies was about the national health system. That's not the most exciting topic, but they made it into a great dance, including using hospital beds. I don't know how they did it. I didn't even know the Brits could dance, okay?
So Renee, close us out. Tell us what is if we were to close your eyes and see the College of Medicine in 5-10 years, what are you ambitioning to see?
Well, what I'm envisioning is that when there is conversation about the top-notch medical school in the United States. You don't hear Stanford. You don't hear Harvard. You don't hear Yale. You don't hear Johns Hopkins. You hear Roseman, and you hear Stanford wants to be like Roseman. Harvard wants to be like Roseman. Yale wants to be like Roseman. And we're just on the top of everybody's lips as the best institution, producing the best physicians, doing good in our communities, and really truly making a difference. So that's what I see, and it's up to you guys. I'm watching.
Okay.
We accept the challenge.
We got to get back to work, guys.
Yes. We're on the clock. We're on the clock.
And that means about 7 more cups of espresso. Renee, thank you so much for hosting this with us. And not only that, but thank you so much for allowing us this opportunity to be part of the Roseman family. This is Cuba Pete, No Laughing Matter, and even when you're dealing with serious subjects like improving people's lives and producing the future workforce, there's always room for a little smile and a little laughter. Thank you.
They call me Cuban Pete. I'm the king of the rumba beat. When I play the maracas, I go chick, chiggy, boom, chick, chiggy, boom.